Thank you very much, Darren, and thank you very much for inviting me to present this paper today. So as Darren mentioned, this is work funded by the IRC through the New Foundations grant. And the paper title is Risk Perception and Vaccine Incentives in the Context of COVID-19. So just to begin with a brief introduction, so we're all familiar with the challenges at this stage that the COVID-19 pandemic has presented us. But one challenge that I'm focusing in on here is the new challenges presented in communicating health risks. So these challenges have really been amplified by the fact that the information has been changing as more data was gathered on the novel virus. And so we've got vast amounts of data available worldwide, and we know that the risks of catching COVID and the risks associated with catching COVID are very personalized and depend on numerous factors. So vaccines are regarded by most in the scientific community as the way out of the pandemic. And we've seen particularly of late that transmission in Ireland is high despite our very high vaccination rate. So boosters have been needed because of waning immunity and may well be regularly needed. So the vaccine uptake is as important, and booster uptake as ever. So this research focuses on looking at how we can encourage this largest vaccine and booster uptake as possible. So just to begin with some of the research questions from the paper, the project is using a nationally representative survey to investigate, first of all, how Irish people perceive their personal risk of death from catching COVID-19. Secondly, how can we best communicate information to improve the perceptions of transmission risks of COVID? And then finally, in the context of vaccines, how can we best communicate information on vaccines? And can we implement policies that increase or incentivize vaccine uptake? So these research questions were investigated using, as I said, a nationally representative survey. And the survey was administered by Ireland Thinks. So they have a nationally representative panel, which they recruited initially based and matched on census data. So matched in terms of age, gender, voting behaviour, educational attainment, and so on. So how the survey was administered, it was administered the second last weekend in June last year, so June 19th and 20th in 2021. And participants received a text and/or an email asking them to participate in the survey. So there were two elements to the survey. So some of the survey questions were answered by all participants, and some of the survey questions, the participants in a treatment group were presented with additional information before answering those questions. So this experimental survey design, the treatment and control groups were matched on age and gender. So the total sample size was just over 1,200. And you can see here that each group, control and treatment group, was just over 600 participants. And for both the treatment and the control group, the same number of males and females from each of these age groups were included. So before I go through the survey and take you through the design of the survey, let me just present you with some summary statistics on the respondents. So first of all, as I'm sure you're aware, two of the most important or relevant risk factors with COVID are age and underlying conditions. So participants were asked to report their underlying conditions, and overall there were 58% of respondents who reported no underlying health conditions. So if we break that down just across the genders and across number of conditions reported, slightly more females than males reporting underlying health conditions. And you can see that there were respondents, the biggest percentage reporting just one underlying condition, but quite a number reporting 2 or more underlying health conditions. And the listed conditions on the survey were those that were known comorbidities or reported comorbidities with COVID-19, but there was also an option for participants to state that they had some other long-standing health condition. Initially looking at this data, I wondered, was it very representative? Only 58% of respondents reporting no underlying health condition might strike some of you as being quite a small percentage, but actually it's in line with other studies in the Irish context. So, for example, Tilda did a report in 2020 on the prevalence of comorbidities in the over 50-year-olds in Ireland. And they found that 50% of those aged 50 or older had, for example, hypertension. So quite a significant proportion of those having hypertension. Additionally, so obesity is listed as a comorbidity or an underlying condition that we know is associated with a higher risk from COVID. And if you look at the Eurostat figures on this from 2019, about 26% of Irish adults are classed as having a BMI of over 30. So it is pretty representative, I think, of the general health status of the Irish population. The second set of summary statistics I want to show you is the vaccination status of participants in the survey, because at the point that the survey was administered, so you may remember that we began offering the vaccines, first of all, to those with underlying health conditions and then by age cohort. So by the end of June, everyone with an underlying health condition and most of those aged 60 plus would have been offered or received at least one dose and perhaps be fully vaccinated at that point. So here you can see that the percentage of those who were fully vaccinated, so more females than males, received one dose, and then there was a number who hadn't yet been offered a vaccine. The numbers who'd refused a vaccine were really, really small. So there were 24 individuals who reported that they'd refused a vaccine. Of those 24, 17 of them, the vast majority had refused the AstraZeneca. And again, just to put this in context, you might remember just before the survey was administered, was when the media coverage of the rare side effects of the AstraZeneca vaccine were very well publicized. So at the time, there would have been perhaps some concern over that particular vaccine. So as you'll see in the survey design, because of that, the questions are separated by type of vaccine, but we can have a look at that later. So just onto the survey design, there are two sections in the survey. The first one is looking at risk, and the second section is looking at vaccines. So first of all, in the risk section, all participants are asked about their perceived risk of death from COVID-19. And in the vaccine section, all participants who are not yet fully vaccinated are asked about their likelihood of accepting a vaccine. Additionally, there is a treatment that has been developed in conjunction with Colleen, who is a senior medical officer in the HSE. And that treatment is used both in the risk section to try and best communicate the data, or the best data that was available at the time on the risks of catching and transmitting COVID-19 to those who are in the treatment group. So, however, you'll see when we get to the results, this treatment actually has little or no impact on people's perception of risk of catching or transmitting COVID-19. A treatment was also developed to best communicate how vaccines work and the high benefits versus low risks associated with vaccination. And you'll see when we get to the results that the treatment had some effect on people's likelihood to accept an adenovirus vaccine, that's the AstraZeneca or the Johnson & Johnson vaccines, but not on their likely uptake of an mRNA vaccine, so the Pfizer or Moderna vaccines. Okay, so let me take you through the first section of the survey then, which is looking at risks. So all participants, just over 1,200, were asked, first of all, if they caught COVID-19 again or for the first time, how likely did they think they would be to die from it? And this was a 7-point scale that ranged from 1, extremely unlikely, to 7, extremely likely. To put their perceived personal risk in context, I also asked them to report for a number of different personas, so 4 different individuals described below, how likely they thought each of these individuals would be to die if they caught COVID, and answers on the same 7-point scale. So you can see there's a range of ages and individuals that are reported to have no underlying and some underlying health conditions. So using the information they gave on their own perceived risk and the risk that they perceived each of those 4 different personas to be from COVID-19, I calculated a risk differential. So the risk differential is simply taking the number that they report their own risk to be. So if they think that they are, for example, extremely unlikely to die from COVID, they would report their own risk as 1. And then subtract the average of the risk that they report for each of those 4 different personas. So to remind you, each of those 4 different personas, they have reported a number between 1 and 7 on that persona risk of death. And I've simply taken the average risk for those 4 personas and subtracted it from their reported own risk. So this gives us an idea of how risky they perceive themselves to be relative to how they perceive the risk to others from death from COVID. So the theoretical range then for this risk differential variable is -6 to 6. In other words, if I think that I'm at very low risk of death from COVID, I report my own risk as 1. And if I think all of those 4 personas are extremely likely to die should they catch COVID, I'd report all of those persona risks as 7. So that then my risk differential would be -6 in that case. At the other end of the spectrum, if I perceive myself to be at very high risk, I report myself as a 7. And if I report everyone else to be at very low risk, I report them all as a 1, then I would report that risk differential would be a 6. Now, the actual range is between -5.75 and 4.75. So a big variation in this risk differential across individuals. And this is what the risk distribution looks like. So you can see, first of all, one of the interesting points to note. So this is 0, where you pretty much think that you're at the same risk as the average risk of those 4 different personas. And you can see that the vast majority of individuals perceive themselves to be at lower risk than others. So perhaps some evidence of an optimism bias here, whereby we really have most individuals thinking they're at lower risk of death from COVID than others. The median risk reported is -1.25. So we've got a distribution here that's more negative or more individuals in the negative range. The other interesting thing to note is if we look at the risk differential distributions by age. So each of these are box plots is an age group. So this age group 1 here is the youngest age group, 18 to 24-year-olds, increasing in age up to group 6 is those aged over 65. And what you can see is that the perceived risk is increasing pretty much linearly with age. So everyone who is between 18 and 24 perceives themselves to be at lower risk than others. And we still have some who, in all the older age groups who have the same perception, but we see that the average perceived risk is increasing linearly with age. So the next part of the analysis then, I looked at the determinants of this perceived risk of death from COVID-19. So in this table, I'm presenting the results of an OLS regression, where the dependent variable here is that calculated differential risk. And then there's a number of demographic variables as explanatory variables that I'll go through now. So the OLS results are presented here because they're easier to interpret, but these results are robust to a multinomial logistic regression as well. So if we look first of all in the first column, as I mentioned at the start, the sort of well-known risk factors from COVID are age and underlying health conditions. So in the first specification here, it's simply a regression with the differential risk as the dependent variable, and with age and this dummy variable that takes the value 1 if the person is healthy or if they've reported no underlying health conditions, and 0 otherwise. And what you can see is that the perceived risk from death from COVID-19 is increasing with age, and those who have no underlying health conditions consider themselves to be much less at risk than those who have underlying health conditions. In the second column, I've added in a variable that takes the value 1 if the individual is fully vaccinated. So to see if vaccination status has an impact on perceived risk. And interestingly, actually, those who are fully vaccinated in each of these 3 specifications here, there's no statistically significant difference between those who are fully vaccinated and those who are not fully vaccinated in terms of their perceived risk of death. What we do see is if we look at this tested positive dummy variable, so again, this takes the value 1 if somebody has previously tested positive for COVID-19, and those who have had COVID previously perceive themselves to be at lower risk in each of these 3 specifications, although it's only statistically significant at the 10% level. And then finally, in this specification, you can see that females, there's no difference between males and females in terms of their perceived risk of death from COVID. In the last 2 specifications here, columns 3 and 4, I've replaced the healthy dummy variable with the number of health conditions that the individual has. So as you saw, there were individuals who had up to 5 underlying health conditions, and many who had no health conditions. And what we can see here in columns 3 and 4 is that the perceived risk of death is increasing in increasing number of health conditions. In the last specification here, there are lots of demographic controls included. So controlling for education, for income, for religiosity, for voting behavior in the 2020 election, and for geographic region. And none of those are helpful in explaining the variation in perceived risk of death. What's interesting in particular, because I'll show you some results on voting behavior and vaccine uptake later. What's interesting here is that, just to note, there is no difference in the perceived risk of death from COVID among individuals who voted for different political parties in the 2020 election. So it doesn't help us explain any of the variation in the perceived risk of death. So the second part of the risk section looked at transmissions risks from COVID. And this was the part of this first section that implemented the experimental design. And those in the treatment group were offered additional information on how COVID is transmitted and some mitigations that can help to stop the spread of COVID. So the information that was presented was firstly about COVID being transmitted by respiratory droplets. Secondly, about the effectiveness of masks. So the most up-to-date information on how effective masks were at the time of administration. Information on how much higher transmission was indoors rather than outdoors, and information on the estimated number of individuals who are asymptomatic with COVID. So those on the treatment survey received this information. Those on the control survey simply saw these questions. So individuals were asked, again, they're presented with a number of scenarios, and they're asked in each of these scenarios how worried they would be about, first of all, catching COVID, and then separately about transmitting COVID. And so the scenarios that they were presented with was firstly an online meeting, secondly a visit to a supermarket, thirdly a garden party outside, and fourthly a meal with your own household in a busy restaurant. So for the first scenario, this was essentially an attention check, if you like, an understanding check. You would assume that most people should not be very worried about transmitting or catching COVID when there's no face-to-face contact. And so that was the case, although we did have a few individuals that were moderately to slightly worried about this situation, maybe that they weren't reading it or paying much attention. It might be that, for example, they needed to attend meetings or video calls in more public areas, not necessarily in their own homes. So the more interesting scenarios are the scenarios 2, 3, and 4, where individuals were asked to rate, again, remember on that Likert scale from 1 to 7, their risk of catching and transmitting COVID. And what we see here, so you can see the average responses in the treatment group for each of these different scenarios and in the control group for each of these scenarios. So for almost all of the scenarios, there was no statistically significant difference in the perceived risk of catching or transmitting between the treatment and control groups. The only place where we had a slight increase in perceived risk of transmitting COVID was in the restaurant scenario, the 3 hours indoors eating a meal. So those in the treatment group in this scenario 4 perceived a slightly higher risk, but it's a very small and only significant at the 10% level effect. So really the treatment had little or no effect on the perception of transmission or risks of catching COVID in these different scenarios. So moving on to the second section then, that looked at vaccines. And this section was only answered by those who were not yet fully vaccinated. So the sample's a little smaller, so it's 579 individuals who, at the point of administration, had not yet been fully vaccinated. And again, here we had an experimental design element to this, whereby the treatment group were presented with information that was designed to best communicate, firstly, how vaccines work and how effective they are, and secondly, the very low risk of side effects. So this treatment was designed with Dr. Colleen O'Haggista in the HSC, and we took into account some of the previous research in how we can convey risks and how people perceive risks. So the first point to make is that previous research has shown that if you use an expected frequency out of a particular number, so if you use the 1 in 1,000 people will experience this side effect, if you frame a risk in that way, it conveys a higher perception of risk than if you present the same information as a percentage. So this has been shown in many studies. And so to try and present the information and the risks associated with vaccines in a more neutral way, we included in the treatment both the expected frequency out of a particular number and the percentage to try and kind of mitigate this higher risk perception when the risks are presented as 1 in 1,000 or 1 in a million, as they often are. The second element that we considered in the design of the treatment is that previous research has shown that when messages contain the details of both the mechanism and the probabilistic information, people are more able to understand the risk. So if we explain the mechanism through which the vaccines work, in addition to giving people that probabilistic information, this enables them to understand the risk more effectively. So the information then that was included on the treatment survey. Again, just to remind you, at the time in Ireland, people were being offered the mRNA vaccines and the AstraZeneca and Johnson & Johnson vaccines. So we presented the information on both of these vaccines and asked them about both vaccines separately. So the first part of the information on the treatment survey was about how the mRNA vaccines work. And the second part was on how the so-called adenovirus vaccines work, the AstraZeneca, the Johnson & Johnson, and particularly explaining that neither of these vaccines affect or interact with our DNA in any way. Then people were presented with the information on the risks, which were highly publicized around the time of administration of the survey, the risks of blood clots from the adenovirus vaccines. And so we told people the number of doses that had been given in the UK, and then presented them with both the percentage of individuals who had the side effect and the frequency, the 1 in 250,000. Similarly, the same information on the Johnson & Johnson. So the number of doses given, the probability of this, or the percentage of people who experience the rare side effect, but also then the frequency of giving them the same information, but in a more neutral way. And then finally, we added the information about the effectiveness of both of the vaccines. So those in the treatment survey read that information first, and then were asked these questions. Those in the control survey were simply just asked these questions. So they were first of all asked if they were offered the adenovirus vaccine tomorrow, how likely would they be to take it? So again, on the Likert scale of 1 extremely unlikely to 7 extremely likely. And then they were asked the same question about the mRNA vaccines. So here is the results, or are the results, looking at the likely uptake across the treatment and control groups for the 2 different vaccines. So here we're just looking at the difference, the treatment versus the control, and you can see that those in the treatment group were more likely to accept the adenovirus vaccine than those in the control group. So a small difference, statistically significant at the 10% level. Those, when individuals were asked about the mRNA vaccine, those in the treatment group and those in the control group, there was no difference in likely uptake between these 2 groups. So I mean, it's worth noting, I suppose, that the mRNA vaccine uptake, the likely uptake is quite high as it is. So the average is 6 here, so 7 being extremely likely. So people in general are very likely to take the mRNA vaccine, and you can see that there is a lower likelihood of acceptance of the adenovirus vaccine, and there's some evidence that our treatment may have had an impact on the likelihood to accept one of these adenovirus vaccines, but generally not a very strong effect of the treatment on likely uptake. The second thing that I looked at was the determinants of likely vaccine uptake. And so here, I'm presenting the results of an OLS regression where the likely uptake, so that again, remember, is just the scale from 1 to 7, is the dependent variable, and a number of demographic variables are the explanatory variables here, which I'll talk you through. Again, these are OLS regression results for ease of interpretation, but the results are robust to a multinomial logistical regression as well. So if we look first of all at the first column here, so we know age is an underlying risk factor for COVID. And so unsurprisingly, I suppose, there is a higher likelihood of acceptance of a vaccine with increasing age. And that's actually robust across the different specifications here. The healthy dummy variable, so where an individual has no underlying health conditions here, there's no difference between those with no underlying health conditions and with reported health conditions in terms of their likely uptake. Now, that may be because at this point, those who had underlying conditions that were considered comorbidities may already have been vaccinated. And so remember here, this sample is just those who are not yet fully vaccinated. So maybe that's why we don't see any difference here. What's interesting is that females are less likely to accept a vaccine than males, and that result is significant across all 4 specifications of the model here. If we look at specifications 2 and 3 here, so this is a dummy variable for those who are in Dublin, and so 1 if they're in Dublin, live in Dublin, and 0 if they live in the rest of the country. And in these 2 specifications, that's significant. But when we control for parties that they voted for in the 2020 election, which I'll talk about in a sec, that disappears. But 3rd level education emerges as significant in all 3 of these specifications. So this again is a dummy variable where 1 is individuals who have 3rd level education and 0 is those who do not. So columns 3 and 4, I think, are really interesting because actually past voting behavior explains a lot of the variation in the likelihood to accept a vaccine. So in column 3 here, I've added a dummy variable where it's equal to 1 if the individual voted for one of the government parties in the 2020 general election. So that's this is equal to 1 if the person voted for Fianna Fáil, Fine Gael, or the Green Party. And you can see that those who voted for a government party are much more likely to accept a vaccine that they're offered, controlling for education, health, age, geographic region, and so on. In specification 4, I break that down a little bit more. So here, instead of a dummy variable for those who voted for the government party, those who voted for a government party are the omitted category here, and I've included categories for all of the other parties that they may have voted for, or for those who didn't vote or report that they don't remember how they voted. So I've only included the coefficients on the results that are interesting here, but they're all in the regression. So just to highlight what's interesting here is that compared to government party voters, those who voted for Sinn Féin in the 2020 general election are much less likely to accept a vaccine. Aontú supporters even more so. So they're way more less likely to accept a vaccine than those who voted for government parties. And similarly, independent voters are less likely to accept a vaccine. Those who voted for the Social Democrats in 2020 are actually even more likely to accept a vaccine than government party voters. So here, there's a number of controls that aren't shown. So I'm controlling for income, for religiosity, for tested positive, and so on in this specification. So even though the voting behavior in 2020 doesn't explain any of the variation in the perceived risk of death from COVID-19. It actually explains a lot of the variation in the likelihood for an individual to accept a vaccine. So an interesting result. The second section of the second part of the vaccine section tests a number of policy incentives that could be in place to try and increase or maximize vaccine uptake. So I considered 4 different potential incentives that could be in place, and individuals were asked that for each of the questions below, just to consider the vaccine type they would be most likely to take. So for example, if they prefer the mRNA vaccine, think about this in terms of the mRNA vaccine. So the first incentive was if you received a €50 hospitality voucher when you were fully vaccinated. Second was if a pop-up clinic was located in your place of work or your college or your town centre, how likely would you be to be vaccinated? If a vaccination certificate was required to attend large-scale events, such as concerts or festivals or matches. And finally, if a vaccine certificate was required to travel abroad without mandatory quarantine, how likely would you be to get vaccinated? So each respondent was asked these questions, and then I compared their likelihood, so remember on a scale of 1 to 7, under the incentive to their reported likelihood without the incentive in place. And what I found was that actually, on average, people were less likely to accept a vaccine under the incentives than they were when there was no incentive in place. So the biggest negative response was to the hospitality voucher. So the difference between the average under the incentive and the average for the vaccine they were most likely to take was 1.18. Okay, so they were much less likely to accept the vaccine when the voucher was in place than when it wasn't. But there was a negative response to all 4 of these incentives, statistically significant, but smaller for the other incentives. The smallest being the travel, that had the least negative response, but all a significant negative effect of the incentive. Now, this might warn about unintended consequences of putting these kind of policy incentives in place, but also, of course, it's important to note that these are just reported likelihoods of acceptance. And it may be that people were registering their opposition to such incentives by reporting a lower likelihood. That may not necessarily result in them not getting the vaccine if the incentive was actually in place. So certainly it shows that these incentives are not particularly popular, but it doesn't tell us if this would actually translate into lower uptake under those scenarios. So to delve a little bit more into this negative response to the incentives, I had a look at the demographic effects of how people responded to the incentives. So a lot of people were pretty neutral. They reported exactly the same likelihood of taking the vaccine under the incentive or before the incentive was put in place. There were and a significant number who were negative reported that they would be less likely to take the vaccine under the incentive, particularly in the case of the voucher. But there were no statistically significant demographic differences between those who had a negative response and those who were neutral or positive. So it wasn't that older people or younger people were more negative about them, or that males or females were. Voting behavior didn't explain any of the variations. So there's really no demographic differences across the individuals correlated with how they responded to the incentives. What about the vaccine hesitant though? So those who, as you saw, the sort of average likelihood of accepting a vaccine was quite high. So if we just look at those who were quite hesitant about accepting a vaccine. So I've defined those as people who had answered extremely likely, moderately, or somewhat unlikely, or not sure or neutral about taking a vaccine. And out of the sample of not yet fully vaccinated, there were about 120 of those vaccine hesitant individuals. And if we just look at their response to the incentives, interestingly, they were unaffected, or the voucher didn't have any impact on their likely acceptance of a vaccine. But we see a small positive effect on the incentive for the other three incentives. So travel being the most positive. So it's a small effect, but perhaps an indication that although unpopular, that these kind of incentives may have some impact on the vaccine hesitant. Okay, so I'm going to wrap up and just summarize some of the key findings then. So first of all, majority of people perceive a higher risk of death for others than they perceive for themselves. So some evidence of an optimism bias in terms of our perceived risk from COVID. And it does seem from the data that those risk factors of age and underlying health conditions are very well understood. The treatment that we tested had really no impact on the perception of transmission risks in the survey. And this is kind of indicating that people probably already understand, or at least think that they understand, the risks and the mitigation strategies well. So I suppose it kind of highlights an additional challenge when we have data that is giving us sort of updated information, updated best practices all the time, of communicating these updated risks, or the updated information, when people are sort of already at a saturation point and think that they really understand this already very well. On vaccine hesitancy, really the number who had refused a vaccine at this point was quite low, although as you saw, there were a significant percentage who were not yet fully vaccinated, who are hesitant. And we saw that younger people and females were more hesitant. So again, potentially useful in thinking about strategies targeting particular groups who may be hesitant. One of the things I was interested in is the potential that females were more hesitant because of fertility concerns. So there was a lot of misinformation about the impact that vaccines might have on fertility. So I did look at interaction effects between age and female, and looking at dummy variables for just young females or females under 45, for example, and there's no statistically significant difference. So the hesitancy doesn't seem to be correlated at all with age, so it's certainly not entirely explained by fertility concerns. What I find really interesting is that the voting behavior in 2020 explains a lot of the variation in the likelihood to accept a vaccine, but yet none of the variation in the perceived risk differential. So it's not that the particular cohort of people who vote for Fianna Fáil or Fine Gael, for example, perceive themselves at lower risk from COVID, or higher risk from COVID. It's just the likelihood to accept a vaccine that's explained by these voting behaviours. So it might be that this is indicating that trust in government or in the establishment is an important factor in vaccine acceptance. So when we broke it down by political parties, it was the kind of more establishment, the more kind of long-standing political parties that had the higher acceptance levels, and those who are kind of considered more anti-establishment had the lower acceptance rates. So again, something that might be a very important factor in considering communication strategies and channels of communication for those who may be vaccine hesitant. In terms of the treatment for the vaccine uptake, so presenting the information on how the vaccines work and the risks and so on, we saw that it had no effect on the likelihood of mRNA vaccine uptake, but there was some evidence of a small effect on the adenovirus vaccine uptake. And actually, similar results, so Thorpe and co-authors found similar results in the USA. So they tried to explain how the vaccines worked. And one of the concerns of people who are very vaccine hesitant in the US was the speed at which the vaccines were developed. So they focused some treatments on explaining and communicating, how they were developed and so on. And they found that this had no impact on people's likelihood to accept a vaccine. So they found very similar results, perhaps again indicating that people kind of believe that they know this information at this stage. As you saw, the incentives are unpopular, and potentially when the incentives are put in place, it's crowding out people's intrinsic motivation to get vaccinated. Although there doesn't seem to be any kind of demographic factors that are helpful in explaining who's having those negative reactions to the incentives. And the evidence does suggest that the vaccines may have a positive effect on those who are vaccine hesitant. Thank you for listening. I would really welcome any comments or questions.